Hi everybody, it's Dr. Sloan. We're going to go through all of the GI, liver, pancreas medications. So all of the medications that you need to know for the accessory organs of digestion as well as GI are all in this one PowerPoint. So you can focus on these slides and not worry about the other information that you come across as you're listening to things that have been pre-recorded by other professors. All right. So drug therapy for gastroesophageal reflux disease and peptic ulcer disease is not just a single drug. It's usually a multiple drug approach. Things like histamine 2 receptor blockers like ranitidine, proton pump inhibitors. Remember, those all end in prazole, like omeprazole, lansoprazole, pantoprazole. Mucosal protectants. These are things like amphigel and sucralfate. And those things tend to just sort of coat the stomach. And then antacids like Tums, and then antibiotics like Flagyl or neomycin. We're going to talk about those. So your first drug is a histamine receptor antagonist, an H2 blocker, and it's ranitidine, i.e. Zantac. It's actually sold over the counter, and it blocks H2 receptors on the parietal cells of the stomach, which decreases the volume and acidity of gastric secretions. It is used to treat gastric and duodenal ulcers, GERD, heartburn. Side effects are pretty rare, and so it's very well tolerated, which is why it is over the counter, right? So it has a pretty low side effect profile. Some people don't find this super effective. Other people find it to be exactly what they need. Omeprazole is better known as Prilosec, is a proton pump inhibitor, or a PPI. We will sometimes abbreviate that term. The mechanism of action for this is that it works on this HK-ATPase pump, i.e. the proton pump, which is the, so it inhibits that pump, which is the pump that generates gastric acid. So it's used for peptic ulcer disease, GERD, and effective for Zollinger-Ellison syndrome, which is a pretty rare syndrome, but it's a hyper secretion of gastric acid. Adverse effects are usually pretty mild. It can include headache, nausea, diarrhea, which makes sense if you think about the fact that it is a drug that treats abdominal or stomach issues, that you're going to have some stomach or GI tract type side effects. One thing about this drug is it can cause increased osteoporosis and hypomagnesemia in long-term use. Those are probably the big things that I want you to remember. And then Prilosec is best administered in the morning before breakfast on an empty stomach. And usually it's a once a day med, which is awesome because you just take it once and it keeps working all day long. Calcium carbonate, we know this is Tums. This is also over the counter, which again makes it one of those things where there's a potential for misuse. Plus Tums are sweet, and some people actually sort of eat them almost like candy. And so I think it's one of those items that we need to be aware of how much our patients are taking. Its mechanism of action is that it neutralizes gastric acid and coats the lining of the stomach and esophagus. It can cause hypercalcemia if too much is taken. And I don't know if you remember this from when we were doing acid-base balance, but too many Tums, the carbonate, can actually cause alkalosis. So again, you'd have to take quite a few, but something to remember, because if something can be misused by the general public, it will be, for sure. The other thing about it is that Tums and many other antacids, they tend to block absorption of other drugs. And so you want to be really careful. Make sure if you're going to give somebody an antacid of some sort or a GI protectant, mucosal protectant, that you know what its effect is with other medications that you're giving and that you give it appropriately. Usually there's like a time frame, like don't, spread it out, antacids and whatever else you're giving by X amount of time, 2 hours or whatever. But again, generally very well tolerated, doesn't fix anybody's GI issues, sort of like a Band-Aid. It's more for treating the discomfort associated with like GERD and other things. So it kind of helps in the moment, but long term doesn't really change the underlying problem. Okay, another one to know is aluminum hydroxide or Amphigel or Alternagel. This is an alkaline compound that neutralizes stomach acid. It raises the pH of the stomach acid, and it's for symptomatic relief of heartburn, peptic ulcer disease, gastroesophageal disease. This is sometimes given to people who can't tolerate the calcium or magnesium in other typical antacids. So it's something that you want to, be aware of, because sometimes you'll be like, well, why doesn't everybody get this? Or how come it seems like everybody's mostly taking, Mylanta, but then you've got a few people who take this aluminum hydroxide. So good thing to know. And again, this has to be administered at least 2 hours before or after other drugs because absorption can be affected. So kind of falls into that like group thinking about antacids in general. Drug therapy for nausea, metoclopramide, which is Reglan, and then phenothiazine, such as Compazine, and 5-HT receptor antagonists. We've already talked about metoclopramide in our oncology lectures, so we're not going to cover that. Compazine's kind of a sister drug to that. You're not going to get any questions about that necessarily. And then Zofran. And even though Zofran is in our oncology lecture, I'm going to talk about it a little bit here as well. So remember, Zofran is a serotonin receptor blocker. So 5-HT3 is serotonin, and it blocks those receptors in the chemoreceptor trigger zone in the brain, and works on afferent vagal neurons in the upper GI tract. It's indicated for the prevention of chemotherapy-induced nausea and vomiting. However, it is good for other types of nausea as well. You'll see it used a lot post-op. It can also be used in hyperemesis gravidarum or gravium, which is hyperemesis during pregnancy. There's just certain times in the pregnancy when you shouldn't take this drug and then times when you should. So you want to make sure that you look up the pregnancy category and the safety information if you're going to give it to a pregnant mom. And then, like I said, more effective at preventing nausea and vomiting than suppressing it. So should be given on a regular, kind of around-the-clock basis if you're going to give it for chemotherapy-induced nausea and vomiting. So for constipation, we're going to talk about some bulk-forming laxatives, stool softeners, and stimulants. So Metamucil, psyllium. So this has been around forever. It is as old as dirt, and it's a great bulk forming laxative. The problem is you have to take it with a lot of water, and psyllium swells. So if you take Metamucil and you stir it into a glass of water, which is how most people drink it, you need to drink it pretty quick. Otherwise it makes this big kind of gloppy, goopy, snot in this glass that most people find really unpalatable and do not want to drink. If you drink it right away, it's a little gritty and grimy, maybe a tiny bit slimy, but you can get it down. The psyllium that they sell these days, most Metamucils, most psyllium brands are flavored in some way, so that helps. It's really good for constipation. And, a lot of people take psyllium every day. They take it sort of as a preventative thing. And if you have trouble with like irritable bowel syndrome or other kind of GI issues where you have issues with diarrhea or even constipation, this can be really good. So it's something to think about. Has to be taken with sufficient water. And unlike other stimulant laxatives, which this is not, this is a bulk forming laxative, but stimulant laxatives cause cramping. Bulk forming laxatives really do not. So you just want to make sure that you take them with plenty of liquid. This says 8 ounces of water, fruit juice or milk, and drink immediately, which I told you why, followed by an additional 8 ounces of water. That's really hard to do. So just be really happy if your patient can get it down with 8 ounces of water, and then, refill their water cup and encourage them to keep sipping if they can. Okay, let me go back for just a minute because I want to make sure. I want to make sure that we don't need to talk about colace or dulcolax. I may add those to the end of this lecture at some point. Okay, anyway, sorry, Dr. Sloan thinking out loud. Okay, drug therapy for diarrhea. Opioids and antibiotics. And you're like, opioids? Well, actually, they are amazing for diarrhea because they slow your gut down. And then antibiotics would be for infectious diarrhea. So, this is not really a, this is an anticholinergic med, diphenoxylate with atropine, Lomotil. So it's an antidiarrheal. It is an opioid. The diphenoxylate is an opioid. And it, again, slows transit and allows for more fluid to be reabsorbed. So it's good, and it's the only opioid for use in diarrhea. So the usual dose in this is nothing that's going to really affect the CNS. And so because it's with atropine, the combination of those two really discourages abuse. So you're not going to see people out there like buying up Lomotil so that they can get high. Plus, it would cause them major GI problems as well. It can cause some dizziness or drowsiness. And again, we talked about this in class, but you do not want to use this medication if you suspect a diarrhea that's caused by an infection or a bacterial problem of some sort. Okay. Flagyl, metronidazole or Flagyl. And I wrote on here the GI antibiotic. So again, we talked about this in class, and it is one of those. Sorry, that's my dog, Lacey. All right, sorry about that. Lacey's protecting me from some unknown critter outside. So anyway, we talked about metronidazole and how it was used a lot for GI infections, often used around the time of GI surgery. It's used to treat C. difficile infections that cause diarrhea. And C. diff, again, remember, is a bacteria that lives in our gut all the time, is kept in check by good bacteria that we have in there. But, when you take antibiotics or have some massive diarrheal disease that sort of clears out your gut and clears out all those good bacteria, then you can have an infection. So this is what would be used for C. diff. It can cause anorexia, nausea, metallic taste. Yeah, again, just kind of remember this is a GI antibiotic. So, of course, the side effects or adverse effects are GI related for the most part. Don't worry about the bone marrow suppression because it is rare. And then nursing care, just extended release. If you're going to take it orally, must be swallowed whole and taken on an empty stomach. Okay, drug therapy for inflammatory bowel disease. So steroids and sulfonamides. So the sulfonamide we're going to talk about is sulfasalazine. or sulfazine. It is a 5-aminosalicylate sulfonamide. You need to be careful in giving this medication. Certainly don't give it to people who have sulfa allergies, but definitely be careful if you're going to give it to somebody with an aspirin allergy, because salicylate, 5-ASA, 5-aminosalicylate, is part of aspirin. It's one of the chemicals in there, and so you want to be careful about that. But the reason that this works for mild to moderate ulcerative colitis is that it is anti-inflammatory. And so it suppresses prostaglandin synthesis and then suppresses the migration of inflammatory cells. But suppression of prostaglandin synthesis is really important. Prostaglandins cause inflammation. Sometimes that's good. You know, our bodies need to respond to things, but in the case of this autoimmune gastric inflammation, that's not so helpful. So we really do want to decrease inflammation. Adverse effects, again, are GI in nature. Big surprise. And again, don't give this to patients with sulfa allergies. So yeah, very well tolerated for the most part. Okay, enteral nutrition, and you're like, why is this in the medications? But again, remember, we talked about this, and we talked about how enteral feeds and parenteral feeds nutrition should be treated like a medication. So we're going to learn it like a medication. So it's given through a tube of some sort. It could be an NG tube. It could be a nasoduodenal tube. It could be a gastrostomy tube, a jejunostomy tube. So that's less important than the fact that it is still going through the gut, right? It is still going through the GI tract, which is why it's called enteral nutrition. And it's usually some kind of formula. They usually don't smell so great. They kind of are like baby formula. You don't want to hang formula you don't want to hang more than 8 hours worth at a time because it can go bad. So you want to be careful about that. And you want to hang it at room temperature. Can you imagine what it would feel like to be getting ice cold formula into your belly? Now, I know we drink cold drinks, but it's different when it's being given from a tube. So be careful about that. And then if you're going to give medications through the same tube, you want to flush before and after medications just to make sure that you really got the medication all the way in, and just to have some kind of a, chunk of whatever med is in there. So if you guys will learn how to give medications through a tube. It's actually really convenient. The thing is, you got to crunch it up and make sure it's really crushed if you have a pill, and if you don't, you have liquid. You just want to make sure that all those liquids play nice together, because you can block those tubes really quick, and then you're going to be not happy camper. Okay, total parenteral nutrition. Remember, we said that par means outside of the GI tract. And so this means that the patient's going to get nutrition through a vessel. Okay. So usually they have a central line of some sort, whether it's a PIC, or they have maybe a port or a Hickman, Broviac, some kind of a line that this gets given to. It's not very well tolerated through a peripheral vein. You could probably do it for a short period of time, but that's not ideal. TPN just has a lot of stuff in it. It can be irritant to the vein. So you want to start slow, end slow, and once you have it up and running, you want to stay constant, meaning that a lot of this TPN can have sugar and other things in it that if you just turn it on and start running right away, the body may not be able to really adjust to that. So you'll have to check with your hospital, but when you have certain percentages of glucose, I believe in our hospital it was anything greater than 12.5% glucose, you had to taper the infusion, you had to taper it up, meaning you would start, really low, like maybe like, you know, 2 cc's for so many minutes, 2 cc's an hour for so many minutes, and then up to 10 cc's for so many minutes. And so that you're slowly increasing the rate at which you give the medication. And then same when you end it as well. It's kind of a pain in the butt. You definitely want to monitor for signs and symptoms of infection because remember we talked about TPN being like super, super bug food. You can also have electrolyte imbalances. Anytime you're giving TPN, you can have significant fluid shifts. So not only from the fluid, just, the volume of fluid that you're putting in, but the fact that you're putting in a lot of other things like albumin and glucose, things that can really shift fluid from one space to another. You want to watch for hyperglycemia and then take vital signs every 4 hours, again, because they are at risk for infection. Ursodiol, I only put it in here. I really debated about whether to put this in or not, but I only put it in because it is used to try to dissolve gallstones. So if you had somebody who's having gallbladder issues, they're not going to go to the OR right away. They might put them on this ursodiol, better known as Actigol, to try to dissolve these stones. It has to be done. It has to be taken 2 to 4 times a day, which is kind of gross, and then it has to be taken for a long time. So it will dissolve stones, but it will take a while. And it works by decreasing the production of cholesterol. And if anybody's ever seen gallbladder stones, they just look like these little brown, kind of shiny stones, and they are made out of cholesterol. Okay, pancrealipase. This is the medication that is given to people who have pancreatic insufficiency for some reason. So our pancreas creates all kinds of lovely enzymes that help us to digest our food and get the most nutritional bang for our buck. So if you have pancreatic issue like pancreatic cancer, pancreatitis, cystic fibrosis with pancreatic plugging, then you would want to take pancrealipase. And it's, considered replacement therapy. So you're basically taking orally the enzymes that normally your pancreas would be pumping out on its own. And you want to give them usually right before a meal. And sometimes there's powdered formula as well. There's we had some sprinkle type enzymes that you could actually put on food, but most people don't like that. They don't want to mess up their food, so they just want to, swallow the pills and then eat what they want to eat without little sprinkles on top of it. This is where sprinkles are not a good thing. But most of the time, sprinkles are a very good thing, especially if they're multicolored and sweet. Okay, the next drug is neomycin. And this is an important antibiotic for you to know in the picture of liver failure. We talked about this in class, and this is really important for you to know. I want you to learn this antibiotic from the standpoint of what it does for someone who's in liver failure. So we know it's an aminoglycoside. Almost everything that ends in mycin is. Tobramycin, vancomycin. Vanco is a little bit different, but anyway, it's a good way to sort of decide if it's an aminoglycoside. And one thing we know about aminoglycosides is that they typically cause nephrotoxicity and ototoxicity. It's kind of like it's like their calling card. So something that you want to be aware of, but it is used for hepatic encephalopathy because it kills the bacteria that produce ammonia in the gut. So we would give this not so much for an infection, but we would give it more to deal with the ammonia issue. And that's really an important difference. Your patient might even ask, like, why am I on an antibiotic? And you would say, well, because it's killing the normal bacteria in your gut that make ammonia, and we're trying to decrease your ammonia levels right now. So again, you would look at things like BUN, AST, ALT, serum creatinine, and ammonia. And like I said, nephrotoxicity and ototoxicity are kind of a hallmark side effects. Lactulose, another yum yum med. This is a syrup, and it's really an osmotic laxative, and probably when you give it in the hospital, that'll be the main reason you're giving it, is you give it, it's a big sugary molecule, disaccharide, and so it will automatically draw tons of water into the gut. But the other thing that it does is it lowers colonic pH and favors the conversion of NH3 to ammonium NH4, and then eliminates it into the feces. So it decreases metabolism of ammonia and draws water into the colon, which induces defecation. So that's cool. So if you think about it, you have a patient with hepatic encephalopathy, they're going to be on lactulose and they're going to be on neomycin. And both of those really are being given as two different mechanisms of action, two different ways that we can reduce ammonia levels. And that may help your patient's mentation and other things. So yeah, that's our drug lactulose. But you may see lactulose being given to patients, just as a laxative as well. And the fact that it decreases ammonia is not going to hurt your healthy patient. Okay, and then our friend prednisone, and I put this on because I really wanted you to go back and just look at this again. So prednisone is a corticosteroid. Guys, we use prednisone in, I bet you, every unit of the hospital. It's used in babies to help mature their lungs. It's used in little kids who have autoimmune and inflammatory things. It's used for asthma. It's used for GI disease and inflammation. It's used in cancer to suppress white cell formation. It's actually part of the regimen for acute lymphocytic leukemia. It is used in older people who have like COPD and can't breathe. So prednisone is one of those drugs that you will see given throughout the lifespan and in almost every single part of the hospital. So it is a drug that you need to know. You need to know it and know it well. So it's a potent anti-inflammatory that sort of down-regulates the immune system. It tells the immune system, chill out, stop being so hyperreactive, everything's fine. Its mechanism of action is that it suppresses the migration of polymorphonuclear leukocytes and reverses capillary permeability. So the two of those things together can really turn somebody around. The side effects, however, are many. The benefits are huge, the side effects are huger. So we want to be really careful when we give prednisone that we don't give it for too long, that we don't just abruptly stop it, because remember, your little adrenal glands in there are like, woo, prednisone, I don't have to make any cortisol. And so they kind of shut down production. And if you all of a sudden stop taking prednisone, you're going to throw those adrenal glands into crisis as they try to rev back up and get back up to speed. We have lots of things in our body that are like that get super lazy when we give outside drugs. Our body adjusts. It's like, oh, homeostasis. I'm getting it from somewhere else. I don't need to make it anymore. So you have to be really careful about that. But the biggest thing to remember about prednisone is if you can begin to learn the common signs and symptoms of Cushing's syndrome, and I'll just remind you that the ones that we think of the most are like moon face, buffalo hump, so chubby face, a fat deposit, usually on the back of the neck, between the shoulder blades, thin skin, sometimes excessive hair growth, and then suppressed immunity for sure. So these patients are at risk for infection. Hyperactivity or mania at high doses. And if you haven't seen that, that is really strange because it can really take someone who is totally normal, doesn't have any history of mental illness, and make them seem mentally ill. And then the other one that you really need to know for prednisone is hyperglycemia. In fact, if we're giving prednisone at high enough doses for a long enough period of time, we can actually kind of create our own little doctor medical caused diabetes. So we call that iatrogenic diabetes, and it can be caused by giving prednisone. In which case, then we just treat the patient like they have diabetes because they clearly need the prednisone, and we'll treat their high blood sugar until they're able to reduce their prednisone or go off. A drug you should know. Okay, that's it. I just realized that we don't have sucralfate, and there's one more on here. So I will give you some information related to those. Probably won't record, just will make you a really quick little couple PowerPoint slides. Okay, guys, I hope this is helpful.